Well, I'm Joan Niekerk, and I have been working at Jelly Beanz one day a week for a period of time, and working with staff, and we've been doing work with children who have inappropriate sexual behaviour, and also doing training with child and youth care workers, social workers, and so on. And
I'm Alida. I've been with Jelly Beanz since 2017. We do individual therapeutic work for children who've been affected by trauma, abuse, or neglect. But we also do group work. We go out into the community, to schools, to different places where we help kids who've been affected by trauma.
Well, thank you very much. A very warm welcome. And we're very excited to hear inappropriate sexual behaviors. Yes, an important conversation. Thank you so much. Over to you.
Thank you very much. It's Vanessa, isn't it?
Yes.
Vanessa, we do just want to say to participants, we would love to have lots of questions and comments because this is quite a difficult area of practice, isn't it, Alida? So we would love to hear from the people who are listening in. And it is linked to a presentation in the previous session by Rion Perry. He kind of has looked at the training of the workers, social workers and child and youth care workers, and we're more looking at the issues with children. So it'd be nice to have questions. So just, shall we just go into it?
Yes, yes, thank you.
Okay. So when children are removed into care, it's important to realize that their traumas move with them. Whatever their background is part of what comes with them into the child and youth care centres. And this is so true when children are placed in child and youth care centres because they're placed with a lot of other children who are also hurting. And this sometimes results in behaviours that may be unacceptable and even harmful to themselves and others. And it's really a challenge for child and youth care workers to manage while still providing nurturing and healing care to all the children within their area of responsibility. And so I just want to emphasize that there are a whole lot of hurting children together in child and youth care centres. So it's not surprising that sometimes their behaviour becomes very challenging. One of the most challenging behaviours is that of inappropriate sexual behaviours, and we call those ISBs, just so that we don't have to say all three words and get tongue-tied. The drivers of the behaviour are multiple and complex. It's not a behaviour that has a simple kind of what would one say, origin. And helping children manage ISB also requires multiple interventions and complex responses. It's not something that you resolve just with a simple group program and so on. It's an ongoing issue that needs ongoing interventions. And many deficits and exposures to violence in the child's history contribute to this kind of behavior. So the therapeutic and psychoeducational work must include the child and youth care workers. And this can sometimes be quite challenging for child and youth care workers. And I just want to acknowledge the amazing work that this group of professionals do. One of the problems is we talk about sex, but we don't talk about sex. You know, sometimes we joke about sex and we tell stories about sex, but we don't really talk about sex in a way that's close to ourselves. And I think that this is quite problematic in many ways because it prevents us from being able to talk about our own sexuality in our own private relationships, but it certainly also makes it difficult to talk to the children we care for about sex. There's also a need for good information about childhood and teenage sexual development. I don't know about all the listeners, but I do know that when I was training and when I work with people who are qualified, even with more recent training, we don't get much good information about childhood sexuality and development. There's also the need for caregivers to feel comfortable talking about sex to children whose early sexual experiences might have been inappropriate, or they may have been exposed to other forms of abuse and neglect, which impact also on sexual behavior. And that comfort is sometimes quite difficult to get to. I do know that when I started working in the field of childhood sexuality, I used to feel uncomfortable about saying certain words and describing sex in very specific ways. And it took a while for me to become truly comfortable talking about things like penises, vaginas, and whatever else have you. So child and youth care workers need to be equipped and able to manage ISBs within the life space of the child, as well as know when to refer a child for more specific therapy for ISB. And both can be very important. That comfort in the life space of the child and dealing with it there is as important as the therapy. And I think this is what Rian talked about in our previous in the previous presentation. And it was clear from the workshops held with social workers and child and youth care workers is that there's a gap in the knowledge base about childhood sexuality. There's discomfort when talking to children about sexual issues. And that the line between inappropriate sexual behavior and appropriate sexual behavior is a bit of a fuzzy one and quite difficult to pinpoint. But also there's a lack of clarity relating to the Child Justice Act, which deals with children in conflict with the law. And certainly many children who are involved in ISBs, inappropriate sexual behavior, are in conflict with the law. It was also clear that sometimes the inappropriate sexual behavior begins to define the whole child in the eyes of others. In other words, this is the child with ISB, not the child with maybe positive attributes and positive behaviors. And who the child really is becomes lost in the label. And sometimes ISB is contagious if it's not dealt with appropriately, because sexualized children who are living in a group context will try and sexualize other children if there's not some kind of intervention. So with the groups that we've run this year, there have, with some of the groups, been pre-group meetings with house mothers, social workers, and conversations with these people in between. What was interesting is that some of the house mothers felt that they were blamed for the incidence of ISB, that they were not actually, how can I say, they were responsible in some way. And the fact that they work alone in their cottage was not recognized. And incidents happen at night when they are sleeping. And believe me, if you're looking after 6 or 7 children, you need to sleep. And sometimes it's more than 6 and 7 children. So sometimes they're scared to report the child's behavior because of they fear blame, and also because of consequences for the child. They don't want their child, who they love but don't like the behavior, or perhaps whom they have developed an attachment to actually go through some kind of legal process. They also told us that they're not sure how to discriminate between inappropriate sexual behavior and normal adolescent development and experimentation. And adolescence is a time of discovering who you are sexually. And there's usually some form of experimentation, either with your own body or maybe with someone else's body during that adolescent phase, that outside of a group home one might see as completely normal. They said to us that they are very unsure of how to speak to children about sex, and also the issue of masturbation. A lot of them kind of struggled with the issue of masturbation, and it was often seen as something really bad. there's also the expectation that children who have a history of sexual abuse will act out, and therefore this sexual behavior can't be stopped. In other words, it's a given, you just have to live with it kind of thing. And the labeling of the child almost becomes prescriptive of the behavior. And the children's sexual behavior, and perhaps even the child, him or her own self, is seen as gross. It's almost as though this is something we cannot really engage with. So our work with the child has to be individual. We must be dealing with children in the life spaces in which they are living, growing, developing. And sometimes there's the need for individual therapy. But very often group-based therapy is very, very valuable. And in this process, whether it be individual or group-based therapy, one should include the day-to-day caregiver who is the continuer. And I don't know if there is such a word, but it was the only one I could think of the therapeutic work in the child's life space. The reinforcer of positive change, and the person who continues to supportively challenge those behaviors that are resistant to change. So some of the important issues covered in the group process when we have worked in groups with children are getting to know each other. Children can live together in the same group home environment, or maybe an environment in which there are several group homes, but they don't really know each other sufficiently to be able to trust each other. So the building of trust in that first session is really very important. And also identifying themes. We might come into the group with a whole lot of stuff that we think is important, whereas the children might say, no, but I think something else is important, and I think you must cover that in your group. So from there, we begin to look at sexuality, health, and development. What was interesting here is this usually took a lot more than one group. Children had lots of questions, and the leader's going to deal with some of those. Some of them quite surprising. I mean, were you surprised by some of the questions you got?
I was.
Yeah. And then we looked at things like sex, consent, and the law. Consent is really misunderstood. And it's quite useful sometimes to talk about consent with young people who kind of feel, well, maybe she didn't kind of protest, so she was okay with it. She was agreeing, not understanding that sometimes people are too frozen to say yes or no to what has happened. We dealt with masculinity, femininity issues and choices and personal triggers to the behavior. Self-control and behavior, anger, conflict, and sexual feelings. Relationships, respect and reactions. Taking responsibility and victim empathy. And then, of course, the groups ended with review, reflection, and assessment. And from here, my colleague Alida is going to continue.
Okay.
Thanks, Alida.
Hard act to follow. So I'm going to talk about the group process. Each session, how we work through all the different topics and themes. So the first part was sexuality, health, and development. And what was interesting is to see how mis or uninformed the children were and how many questions they had. The conversations about sex were facilitated with boys and their caregivers together in the same group. This was helpful as it opened up a space in their relationships to discuss sexual issues as they arise in their day-to-day interaction with less embarrassment. The girls group, however, did not include the caregivers due to their reluctance to share in front of the caregivers. So the girls group was the group that I worked with, so I can speak more openly about them. But in terms of the boys group, that was done by Rian Perry, so I'm going to speak on his behalf. For the girls group, a lot of the girls were on contraceptives, but they did not know why. They didn't know the meaning behind the injection or the other forms of contraception that they took. One of the girls said that I get an injection every 3 months, but I don't know why. And they also thought, those of them who knew the meaning behind the injection, they thought it would also protect them from STIs. So one of the quotes from the girls were, "I don't have to worry about STIs as I am on the injection." They had a lot of questions about menstruation, which was rather interesting. And it was interesting to answer some of the questions and to demonstrate some very basic feminine hygiene things, or demonstrate is maybe the wrong word, to explain some of them to the girls. They didn't understand the differences between the different sanitary pads and products that they can get. And there was a whole 10 minutes or to 20-minute session where I had to demonstrate with a pad on my hand how to put the little pieces together. So it was very interesting to actually show it and how it worked. Some of the girls described symptoms of vaginal infections, but felt so embarrassed to tell their care workers about it. So it was untreated at that stage. They did not understand their bodies and the various holes and the various functions. There were lots of questions about female hygiene and cleanliness. Getting pregnant was misunderstood. One of the girls, actually quite a few of the girls were mentioning this, that you can only get pregnant when you have sex on your period. That was an interesting thing to unpack. They had a lot of questions about masturbation. First of all, they didn't believe that girls could and should masturbate, and that this was something that only boys could and should do. We spoke about rules for masturbation once they realized that it's something that is allowed. The rules were to have clean hands, to be in complete privacy, and no objects that may be inserted. All of the girls in the girls group have been sexually abused. They had a history of sexual abuse. So we had very important conversations about the loss of virginity. As some of the questions that came out with regards to virginity is, are you forever connected to the person who took your virginity? And do you prove your love through having sex with someone? This was quite a sensitive subject to unpack because of the history of sexual abuse, and a lot of these girls losing their virginity without consent and without being part of the decision-making process. We had a long discussion about love languages and how these girls can show their love and affection without using physical ways of doing it. Some comments from the boys' side. Sorry. Some comments from the boys' side, which is very interesting to read it out of context, but I can imagine how it was like. So one of the boys said, "So what you're saying is that if I masturbate a lot, I can still have children when I'm older?" Another question was, "I know I should have said no when she asked me for sex. I know now that I should tell her, no, I'm older than you and I must protect you." And a third quote from the boys was, "Wow, I did not know I could get into trouble for that. I must be careful. Thank you, uncle." This was about a 17-year-old boy talking about him and his girlfriend having consensual sex. In terms of sex consent in the law, the issue of consent was definitely misunderstood by both the boys and the girls. Discussion centered around victim passivity, not meaning consent. The age differences were not understood, so this was a very important conversation to have.
And they are complicated.
It is complicated. Yeah. Responding to a younger sexualized child below the age of consent was discussed, and a lot of information about the law was given. Masculinity in terms of the boys group, the discussion that centered around what constitutes masculinity, it was not just around sexuality and sexual experience. Triggers for inappropriate sexual behavior were discussed, and the boys were encouraged to identify their personal triggers and how to deal with them. Some of the boys found this very difficult. In terms of self-control and behavior, like anger, conflict, and sexual feelings, the discussion was extended to impulse control relating to other strong feelings, feelings that can trigger certain behaviors. Some practical tips were given on calming the sense of being overwhelmed by emotions. Example, a glitter jar and a feeling actions wheel that I did with the girls. And some of the girls were, actually most of the girls were identifying what works for them on a personal level to calm big feelings and big thoughts. And these would help them to distract them from these feelings and then make them do different actions rather than wrong actions.
In fact, you mentioned that the girls were quite inventive.
Oh, yes.
About the distractions and calming behaviors, and had some really great ideas.
They had some really great ideas. Some of the ideas were just literally stepping away, going to sit in a sunny spot, or going to feel the breeze in your hair, just something that takes you out of that big overwhelming moment and gives you a chance to just breathe. So the girls came up with ideas together, and then from those ideas they decided which 8 ideas worked best for them. Is this still me?
Yes.
Okay. I forgot where I was supposed to end. So in terms of empathy and victim awareness, this was more in terms of the boys. The boys found victim empathy very challenging, and after discussion they were asked to write a letter to their victim where they would admit the behavior and take responsibility for their behavior and then ask forgiveness for it. They would apologize for their behavior. Is this now you?
I'm happy to continue. Okay. So the girls group reflected on the group at the beginning of every group and in the last group. And they said they learned a lot about sexuality education, and they liked the whole experience of the group. One exercise in the group was not enjoyed by the girls, and that was the guided imagery exercise in which they had to close their eyes. And in discussion on the girls' responses to this, Alida felt, if I can talk for you, that this appeared to be connected to the girls' feelings of being unsafe. And that's very interesting in terms of their history. They all had a history of having been sexually abused. And as the girls contributed actively to the group topics, they felt more in control of their participation. So enabling them to say, we want to talk about this, but not that, was very important for them to feel, we have control in this group situation. And that's very important, because sexual abuse is the kind of situation in which you feel it's got totally out of your control. And I really do believe that part of the healing process can be giving opportunities to children to take charge, maybe of certain decisions, that they are mature enough to actually participate in that decision making. Some of the boys' comments, where I like it a lot, learning about these things from you. The aunties never used to talk to us about this. It used to be strange to talk to the aunties because they are aunties, but now it is easier. And this was after the aunties, child and youth care workers, were actually included in the groups. And then, Uncle, I'm not doing those things anymore. Uncle, really, I can control myself better now. A comment that was really very encouraging from a child with really concerning sexualized behavior. So what needs to happen next? This is not the end. The intervention is not the be-all and end-all of change. And I think that's really important to remember. These children are in a process of development, and therefore further interventions by the child and youth care workers need to acknowledge that and be appropriate as children move on to each level of development, new experiences that they struggle with, and so on. And the important thing is to see that. Sometimes we think therapy solves all problems for a child. It does not. And it is really important to see, for child and youth care workers, to see themselves as the ongoing encourager of further change in a positive direction. Relationships developed between the children during the groups should be supported and continued. Children became a little closer to each other, and I think that that is quite important. We have to remember that often when children are removed, they also lose contact with their siblings. And sibling subsystems are in actual fact supports for each other. And so where you perhaps have brothers in one cottage and a sister in another, that loss of relationship is quite difficult for children to replace in some way. And when close relationships do develop between children that are appropriate, they should be supported and continued. So the groups end, but the conversations must continue with the children. Those child and youth care workers who have become comfortable or more comfortable talking with children about sexuality issues must continue to do so, because it is not the end. So the child and youth care workers do need to be supported in their facilitation of the continuing conversation in the child's life space. For us, we learned a lot too. I mean, it was really interesting. And I must say, having worked in this field for more years than I care to remember, the exciting thing is you learn something different with every group of children and with every child you work with. What was interesting here is the different therapists had different styles of interaction with the groups. And these possibly related to past training and experience. And both styles were of value and possibly need to become a lot more integrated. So when Alida and I were talking about this morning, she was saying, oh, but Rian did things differently to me, but I can learn a lot from him, and maybe vice versa. And I think this is another thing that we forget. By having discussions, case discussions around children and their families, we can learn so much from each other about how to manage difficult situations. And that's what consultation and mentoring is all about. So what next for the child and youth care workers? Okay, I do want to emphasize that change is slow. You cannot undo a child's years of history in a matter of weeks or months or perhaps even years. And the progress of the child does not proceed in a steady upward line. So there will be times when a child might go backwards before they can go forwards again. For me, it's like a baby learning how to walk. How many times do they fall down before they really are steady on their feet? I mean, I look at my little grandchild at the moment falling on her bottom so many times, and sometimes forward onto her hands. It was a long process. Now she can run. And these children need that space. They sometimes need to have that backward kind of learning experience in order to move forward. So don't see the groups as a panacea for a solution for all the child's developmental needs. Children will need to have further support and responses in their own space that contribute to changes in behavior and sustaining those changes. And I'm the first to accept that child and youth care work is very, very challenging. And therefore, workers who are struggling with inappropriate sexual behavior in the children they care for need mentors. And ongoing mentoring and support is absolutely critical. And it's not because they're bad child and youth care workers, no way. It's often because in the situation itself, they can be caught unawares and then be stuck in terms of, well, how do I actually deal with this situation? And this is where mentoring and discussion is so important. And I think one of the positive things is ongoing training. Even if you've been to a training exercise before on inappropriate sexual behavior, if you're offered another, it's sometimes very useful to go back into training with, you know, I didn't get exactly how to deal with this kind of situation, so that the ongoing training can have a facilitating impact on the ongoing development of skills. So I think that's it. It is. Do you have anything to add, Alida?
No.
Did we leave anything out?
I don't think so.
Okay. But we would like to know what your questions are. So were there any questions in the question box for us? Oh, yes. Stop share. Any questions for us? We
can't hear you.
We can't hear you.
Yeah.
There you go.
Oh, thank you very much, guys. This was quite an interesting topic. Yeah, and there's so much to learn from ISB. I just have two colleagues with me that would like to ask questions. I'm just going to read out the question for you. When we talk to the children about sex, from what age should we start talking to children? Is it from between 9 and 10, or should we go higher? And also, how deep do you have this discussion with the children for certain age groups?
I think one has to start a lot earlier than 9 or 10 and start with the questions that children ask us. For example, a child and youth care worker could be asked, did I grow in your tummy? Okay, that's a lovely opportunity to start talking to children about bodies and how development happens. And then to respond to the child's question and not over answer. Because sometimes we're tempted to give children too much information, kind of like all in a heap, and then children can't remember the important issues. But to give a little bit of information and then wait for the child's next question. Maybe if it's a very young child, to actually respond in terms of, did you understand what I was telling you? But children ask questions also when they hear older children talking. So, you know, a child might hear the word rape and say, what is rape? Can you tell me what rape is? And that child might only be 5 or 6. That child deserves an honest answer, which might need to be linked to giving the child a whole lot of other information as well. If a child has got to the point where they've entered puberty, I think that is often too late because the changes in their body are already kind of new to them and sometimes not feeling comfortable. Like, oh, my breasts have started budding. Do I have cancer? You know, maybe a relative has died of cancer. So one needs to make sure children are well prepared for puberty. They're well prepared for events in their lives, like menstruation, for example. My daughter said to me once, Mommy, I'm so glad you told me about menstruational periods. I can't remember what word we used. She said, because if I started bleeding from my bottom, from my vagina, I would have thought I was dying if you hadn't told me, because children associate blood with hurt and harm. What else would you like to add there? Jelly Bean's book. Yes. Can you talk a bit about that, Salida?
There are many amazing resources that can be used with kids that can guide the conversation if it gets a bit uncomfortable. The Jelly Beanz book called Our Bodies is a free resource that can be downloaded from our website that guides the conversation with very young children. And ideally, these conversations need to happen before they go to school, so that they have all the appropriate knowledge, age-appropriate knowledge, before getting into situations where friends or all the kids might be talking about it and they don't know what's going on. So knowledge is power. Knowledge is always power. There are some very cute books about puberty called The Girl's Guide to Growing Up and The Boy's Guide to Growing Up, which is it has all sorts of clever information in it that kids love to look at. With the girls in the group, what I did is I would give them different sexuality education resources, and that guided the conversation for them. They asked the questions about the book that seemed interesting or new to them. So kids love books. It's the best way to teach them, and it's also easier for adults to work with books with children.
And also, just to say that along with information, we should be sharing values. So if I talk to my child about sexuality, I might say to the child, look, it's like driving a car. Dad's shown you how to drive a car, but you may not drive the car because you're not old enough. And our bodies are the same. You know about sexuality, you know to experiment, but because we don't want you to fall pregnant before you finish school, or because we don't want you to get involved in a very deep relationship at this stage, we would prefer you to wait until you're older. So values are an important part of sexuality education.
Thank you guys. Just another quick question. Behavior change in children with special education needs. How to understand the challenges about ISB. How do you explain for the children? How do you explain that to the children?
I think one needs to, if a child is challenged mentally or challenged in terms of education, because sometimes you can have very bright children who are not able to read and write very well. Maybe they are attention deficit, they might have attention deficit disorder, or they might be dyslexic and find it difficult to read and write. One has to discriminate between the two. For children who need simple literature, the Our Bodies book is excellent. So you would explain sexuality, sexual behavior, parts of the body in a very simple way using the Our Bodies book, which is really designed for either preschool or grade 1 and grade 2, not much older than that. But I have used it with a much older child who seemed to be developmentally delayed, and that was fine. With the children who have particular learning problems, one would do it in an age-appropriate way, but perhaps not use a book as a tool because of the child's reading issues. And it's the same in the one group. They wrote a letter of apologies to their victims, and you can see that some of the children have real issues writing and reading. And so one would look at the child's capacity in giving those explanations and using tools like books and certainly written exercises. A lot of children in child and youth care centres do struggle at school, and quite often that comes from their background. You know, maybe a parent who never took any interest in their school performance, maybe they never got the child up in time for school, and so they seem developmentally delayed. So it is important to really think about the child. What does this child need? And individualize the child. Do you want to add to that?
No, I agree. It's always better to meet the child where he's at. And that I like the idea of answering the questions that they bring to you and giving age appropriate, correct information.
Yeah. Any other questions?
Hi. Thank you very much for that information. And also the children that struggles with substance abuse. The ages are 14 to 17 years old. How do we, can we explain to them about the ISB behaviors?
It's interesting because there could be a link there. A lot of ISB, inappropriate sexual behavior, is quite addictive because sex is pleasurable. Otherwise, it wouldn't become such a reinforced behavior. It's a self-reinforcing behavior because sex is pleasurable. It feels good. And we have to also remember that because it feels good, and often it involves engaging another child in touch, and children in child and youth care centers are often touch deprived. Okay, so it can in actual fact become quite addictive. Some of the ISB work could be appropriate for children who are drug addicted, but I do believe children who are drug addicted need a specific program for drug addiction. And I know that there are very few programs for young children. I know of one in Durban, run by Durban Children's Home, and I really applaud them for picking up the challenge and providing this resource. And along with dealing with the addiction to drugs, one would deal with the inappropriate sexual behavior as well. Triggers become quite important. Triggers for drug taking can sometimes be the same triggers for a child who is involved in inappropriate sexual behavior. And therefore, ways of coping with strong impulses, like Alida described, talking about that. How can I delay the impulse to take a drug? How can I delay the impulse to become involved in something sexual? And what are the triggers that produce that behavior? Can be very valuable to talk to a child about.
Thank you. This confirms everything. I want to thank you guys so much. I think we ran out of time. And yes, I just want to thank you guys very much for all this information, because I know it is quite sensitive, especially here with us in South Africa, to have this conversation with children. But that is very important because they need to know the inappropriate sexual behaviors that are important, and children can't help how they feel because, yeah, this is natural. So thank you very much for all your information. We would really like to thank you.
Yes, we want to thank you. It's been for us lovely to share the experiences we've had.
It has been wonderful. Thank you very much.
Thank you. Thanks. Bye-bye.
Bye-bye, and enjoy the rest of your conference. It looks so interesting. We wish we had time to attend.
Yes. Thank you so much. Blessed day to you guys. Bye.
Bye.